My patient Richard came in for his visit. He had gained 11 pounds. His wife was pushing him to get his health together. I gave him a sample of Wegovy to start. Then I sent the prescription to the pharmacy. A week later, he told me, "Doc, insurance denied it." And I said, "Yes, I know. They always do, but I have a plan." Welcome to your daily health briefing. I'm Dr. Albert Takem. This show is here to help you navigate the complex U.S. medical system, one step at a time. Whether you are decoding a new diagnosis, fighting for a referral, or just trying to stay informed, you are in the right place. Let's get into the science. Today, I'm going to teach you exactly how to get your weight loss medication covered or how to afford it if insurance says no. Because the system is designed to say no. Your doctor's job is to find the loophole that says yes. I see this every single day. Let me give you an example of 3 patients. So Richard is 43 years old, weighs 260 pounds, works at the car dealership, top 5 in sales, being groomed for management. His wife keeps telling him to get his health together. Insurance denied his Wegovy. He was ready to give up and just change his diet, which, let's be honest, rarely works alone. Next patient, Kim, 59, very active, goes to the gym every day, lifts weights. Her weight crept up after the holidays and she couldn't turn it around. Insurance wouldn't cover Wegovy. So what did she do? She went to horse.com and started injecting a compounded product, an unregulated version of semaglutide, because she didn't know there was another option. Another patient, Doug, is in his 60s, lost 10 pounds on Zepbound, doing great. But he asked me, "When I reach my goal weight, do I have to stop? Because everyone says you gain the weight back." He was worried about long-term coverage. 3 patients, 3 different insurance problems, same disease. And in every case, the system made it harder for them to get the treatment for a disease that the American Medical Association recognized as a chronic disease all the way back in 2013. That is 13 years ago. Here is what patients don't know. The insurance denial is not the end of the conversation. It's just the beginning. So let's delve a little bit into the science and see what the insurance landscape looks like in America when it comes to coverage of weight loss medications, especially the GLP-1s. So let me break down exactly how the system works and how to work the system. When Medicare Part D was created in 2003, drugs used for weight loss were explicitly excluded from coverage. At the time, the available medications were marginally effective and had unfavorable side effect profiles. So Congress decided that they were cosmetic, not medical. That exclusion has never been formally repealed, even though the science has completely changed. Today, GLP-1 receptor agonists, which you know as the Zepbounds and Mounjaro, Ozempic of the world, produce 15 to 21% body weight reduction. They reduce cardiovascular events by 20%, that is heart attacks and strokes. They treat fatty liver disease, sleep apnea, heart failure, and chronic kidney disease. They are among the most important medications developed in the last 20 years. But the law still treats them like diet pills. But for private insurance, the picture is a little bit more mixed. Only about 1/3 of U.S. employers' commercial insurance companies cover weight management medications. Many employer-sponsored plans explicitly exclude them. We still see that today. And even when the plans do cover them, they often require a prior authorization. That's a process where your doctor has to call the insurance company and justify why you need the medication. Another roadblock they put on the way of the patient getting the medication. And sometimes, even when your insurance covers it with the prior authorization approved, might turn out that the patient still has to fork out $800, $600 for these medications as his copay. A 2025 study of Medicare Part D plans found that While over 90% of plans now include GLP-1 medications on their formularies, prior authorization requirements have surged, meaning the drugs are technically covered but practically inaccessible without significant administrative effort from your doctor's office. This is also a reason why we had to introduce a prior authorization fee, because insurance denials have skyrocketed, patient demand for the medication skyrocketed, and so the administrative burden of getting patients the care they need also skyrocketed. That's why we had to use this fee to get additional staff dedicated to taking care of prior authorizations. Now, here is what your doctor should know, and this is what I do in my practice every day. Insurance companies often deny coverage when the diagnosis code is obesity, but the same medication prescribed for a different FDA-approved indication can get covered. This is not fraud. This is using the full scope of FDA-approved indications to get patients the treatment they need. As we say here, when insurance companies build a 10-foot wall, we find a 12-foot ladder to scale it. Okay? So here is the strategy. If a patient has obesity and sleep apnea, which 70 to 80% of patients with severe obesity do have, I can prescribe Zepbound under the sleep apnea indication. If a patient has obesity and cardiovascular disease, I can prescribe Wegovy under the cardiovascular disease risk reduction indication. If a patient has obesity and type 2 diabetes, I can prescribe Ozempic or Mounjaro under the diabetes indication. If a patient has obesity and fatty liver disease with fibrosis, I can prescribe Wegovy under the fatty liver disease indication. This is exactly why the comprehensive workup matters. When I screen every patient with obesity for sleep apnea, fatty liver disease, cardiovascular risk, and diabetes, I'm not just being thorough. I'm building the medical justification that gets the medication covered. Every comorbidity, that is every additional disease I diagnose, is another door that insurance has to open. For Richard, insurance denied Wegovy for obesity, but if his sleep study comes back positive for sleep apnea and with a BMI of 32 and a neck circumference consistent with risk, there is a good chance it will be approved. I can prescribe Zepbound for sleep apnea. Different door, same result. Now, after all of this, sometimes the insurance company still says no. And this is where another option exists. Kim didn't know about this. Most patients don't. Both Novo Nordisk, that is the manufacturer of Wegovy, and Eli Lilly, the manufacturer of Zepbound, offer direct-to-patient purchasing programs. For Wegovy, patients can purchase directly through their online pharmacy called NovoCare Pharmacy with a prescription from their doctor. Novo Nordisk recently reduced the self-pay price. The injectable went from $499 to $349 per month, and the new oral tablets cost between $149 and $299 per month, depending on the dose. This is way more affordable than the $1,000, $800, $600 patients were paying at the pharmacy a year or two ago, and usually even more affordable than all the online subscription plans that supply patients with compounded medications, but more on that in a few minutes. For Zepbound, Eli Lilly offers Lilly Direct, where patients can purchase the medication with the prescription. Pricing also varies by the dose. These are FDA-approved manufacturer-produced medications, not compounded products. They are the real thing, with verified concentrations, sterile manufacturing, and lot tracking. When I told Kim she could get the FDA-approved Wegovy directly from the manufacturer for a comparable price to what she was paying for compounded semaglutide from House.com, she said, "I didn't realize that was an option." She switched immediately that day. So that is the power of information. Now, I want to be honest with you about something. The system is not designed to help you. It's designed to save money. And the easiest way for an insurance company to save money is to deny your claim and hope you give up. Most patients do give up. They get the denial letter, they feel defeated, and they go back to trying to lose weight on their own, which for most people with obesity doesn't work long term. That's not a character flaw, that's biology. Obesity is a chronic disease with neurohormonal drivers that fight against weight loss. The medications exist because willpower alone is not enough for most people. So here's what I need you to understand. A denial is not a no, it's a not yet. Your doctor can do a peer-to-peer review. That's when your doctor calls the insurance company's doctor and argues your case directly. Your doctor can use a different diagnosis code. Your doctor can switch to a different medication with a different indication. Your doctor can send the prescription to the manufacturer's pharmacy instead. But your doctor has to know these strategies, and you have to advocate for yourself. If your doctor gets a denial and says, well, there's nothing I can do, that's not true. There's always something. The question is whether your doctor is willing to fight for you. In my practice, we allocate staff time specifically for prior authorizations. We do peer-to-peer reviews personally. I've written letters to insurance companies explaining why a patient needs this medication. It's part of the job, because if I diagnose a disease and then can't treat it because of a bureaucratic barrier, I haven't done my job to completion. And I'll say this to every insurance company executive who might be listening. You will pay for obesity one way or the other. You can pay $350 a month for Wegovy now, or you can pay $100,000 for a heart attack later. You can pay for Zepbound now, or you can pay for dialysis, liver transplant, CPAP machines for the next 30 years. The math is not complicated. Help patients get their medications because prevention is always cheaper than the catastrophe. Now, as we wrap up this episode, I have 7 action items for you as you battle insurance companies and their refusal to cover weight loss medication. Number 1, get the full workup. Before your doctor prescribes a GLP-1, make sure you've been screened for sleep apnea, fatty liver disease, diabetes, cardiovascular disease, and other comorbidities. Every diagnosis is a potential pathway to coverage. Number 2, if insurance denies the medication for obesity, ask your doctor to resubmit using a different FDA-approved indication. Zepbound for sleep apnea, Wegovy for cardiovascular risk reduction or fatty liver disease, Ozempic or Mounjaro for diabetes. The medication is the same, the door is different. Number 3, if the first appeal fails, ask your doctor to do a peer-to-peer review. This is a phone call between your doctor and the insurance company's medical director. In my experience, many denials are overturned at this step. Number 4, ask about oral options. The Wegovy pill, oral semaglutide, in various doses is FDA approved for weight management and usually costs anywhere between $149 to $299 per month through the manufacturer. Some insurance plans cover oral medications more readily than the injectables. Number 5, ask about direct manufacturer purchasing. NovoCare Pharmacy, Wegovy, Lilly Direct for Zepbound. Your doctor sends a prescription directly to the manufacturer and they ship it to you. No insurance needed, FDA-approved products, real medication. Number 6, if you have private insurance, check for manufacturer co-payment cards on the drug company's website. This can reduce your monthly cost to $25 a month. Number 7, do not use compounded GLP-1 products. The American Diabetes Association, the American Association of Clinical Endocrinology, and the American College of Cardiology all recommend against them. They are not FDA approved. They have documented safety concerns, including dosing errors 5 to 20 times higher than intended, hospitalizations, and contamination. There are legitimate, affordable alternatives. Please use them. The system wants you to give up. Don't. Your health is worth the fight. I'm Dr. Albert Takem. I will see you on the next one because the fight for your health doesn't stop here. This has been the Daily Brief. Medicine is not about certainty. It is about responsibility. Decisions are often made with incomplete information, but they are always made with your safety in mind. In a system that can feel rushed and fragmented, you deserve clarity, continuity, and an advocate who sees the whole picture. I am Dr. Albert Takem, your physician ally, high-level science, human-level care. I will see you at the next briefing, or I will see you in the clinic.